All right, everybody, we're going to get started. Thank you for attending this lecture. As some of you may know, this is part of our residency curriculum. Our curriculum is based on the 3 pillars of medical education: the science of medicine, the art of medicine, the business of medicine. Today's talk is certainly going to, focus on the business of medicine. I'd like to first extend a warm thank you to Drs. Katz and Raboli and the other members of the Rowan community for allowing us to use this room this afternoon. Thank you very much. Our next speaker, I don't think needs any introduction to our residency. Our residents have known him quite well. He's actually given a few lectures already to the residents. He's actually the father of our 4th-year chief resident, Dan Fabius. Dr. Ray Fabius has seen it all, I think, pretty much through medicine. He was a primary provider at one point. Then he worked with the insurance companies, has worked with multiple corporations, focusing now on a lot of innovative strategies for population health. And in fact, he's written the textbook that Thomas Jefferson is now using for their new school of population health. He's written multiple white papers on healthcare reform, what needs to be done, and he's a very energetic speaker, as you will see. He will be very entertaining and and certainly very instructive, I think, with some of his innovative concepts. So without further ado.
Can you hear me? Oh, wonderful. Thank you so much for this opportunity to share some thoughts with you. What I was asked to really talk about today is a topic very similar to a topic that I presented to the residents here just a couple months ago. And we got halfway through, and now we have some medical students. So we're going to actually go back to the beginning to catch you up on the first half, but I'm going to try to do this quickly so that the residents can actually hear the second part of this presentation, which is really focused on 5 enduring healthcare trends that really are important for us to consider as true healthcare reform, regardless of what happens in the legislation. And it's always good to start with taking a historical perspective, since my wife and Dan's mother is a historian and a history teacher. This is always a good place to start. So I think that's particularly good for medical students because you have this opportunity now to actually question everything that you're being taught. I did that in medical school, and I didn't endear myself actually with the faculty by doing that. So you have to be careful how you make these questions. But I used to even question very simple things like, well, why do you give the antibiotic for 10 days instead of 8 or 10 or 7? And the answer usually was, well, you either give antibiotics for 3 days, 5 days, 7 days, 10 days, or 14 days, because that's the way we've always done it. So, questioning even simple issues like the length of therapy, asking for papers that actually support why you do certain things becomes increasingly important now, particularly as we are trying to combine science with the art of medicine, and as we're trying to take care of the costs of healthcare at the same time as creating more efficiencies. So today, in the time that I have to spend with you, I want to cover very quickly the status of healthcare reform policy, some unresolved problems in the healthcare system, which will be your challenge, particularly you that are residents and medical students, you're going to have to lead the way through these issues that we're going to, as more senior practitioners, leave you with. Still relatively unsolved, I'm sorry, but I think we actually have a path for you because we have some trends that we're beginning to produce now for true healthcare reform, and we're also developing a new vocabulary of healthcare reform. But to get things started, I will actually discuss these unsolved problems, the key unsolved problems in this country that we need to deal with. Now, as a doctor, I wasn't really happy with the notion that 9 attorneys were going to decide on whether or not the Accountable Care Act was constitutional and good for our country or not. Think about that. It's as if there was an opportunity for the last 9 surgeon generals to decide on court reform for the legal system. And I don't even think that the founding fathers would have wanted it this way, but in the end, the decision of the Supreme Court, as you know, was a 5-4, very close split decision to approve the Patient Protection and Accountable Care Act, which is the most major reform of our healthcare system, since our country has begun. And interestingly, it upheld the concept of an individual mandate, which means that everybody has to have health insurance, and that will change the way you're able to deliver care in this hospital, knowing that every person who comes in will have some kind of coverage. And then at the same time, it gives these states the opportunity to not engage in Medicaid expansion for the poor, which actually still creates a little bit of a loophole where some people who are poor and may not qualify for the expanded version of Medicaid may still show up at your hospital without coverage. But New Jersey is not one of the states that I'm aware of that's considering opting out, so I think you'll be fine. It's important to know that even if the individual mandate hadn't passed, there still would have been about 50%, half of the people who are presently not covered with insurance would still be covered because of the employer mandate. So in part of this legislation says any employers that have over 50 employees have to provide health care coverage, or they have to pay a penalty. And so the small businesses, the ones with less than 50 employees, are getting a remarkable break in their taxes by providing coverage. And so the feeling is that for the smaller employer, there may actually be some interest in providing coverage because of the tax credits. Anyway, it becomes less of an issue because more people will actually have an insurance card. Before there was the Accountable Care Act, there was a big stimulus package that was passed in 2008-2009 period to try to kickstart the economy. And one of the component parts of that stimulus package was actually to provide a remarkable incentive to doctors and hospital systems to build an electronic medical record and to use it meaningfully. And in fact, on the back end, there's also a penalty with a reduction of your payments on the Medicare side if you don't have an electronic medical record. And so finally, as a consequence of this incentive and penalty, we are actually seeing the future where everyone, all hospitals and doctors will be on an electronic medical system. We think that may happen, in the 2016, 2015, 16 period. When I was in medical school, which I like to kid was in the mid-50s, not quite that far back, I was told by my professors that the electronic medical record was right around the corner. Actually, I trained at Children's Hospital. I trained at Children's Hospital Los Angeles for my residency, but I went to Hahnemann across the river for medical school, and and graduated in '77. And so there was an electronic medical record that was being played with in the medical library. We had simulations of patients that we could actually treat, on a computer. It was a lot less sophisticated, but I just wanted to give you some sense that we have gotten not that far in healthcare since 1977, but I think we finally have a shot here now. All right, so there are three issues that face this country that have to be fixed by true healthcare reform. One is that we spend a lot of money in healthcare, but not wisely. Two is there's amazing variations in care that we can't explain in this country. And three is we don't really perform well when we compare our performance to other countries in terms of the delivery of care against evidence-based guidelines. And I am the chief medical officer of a company called Truven Health Analytics, which was formerly Thomson Reuters Healthcare. And we are perhaps the largest repository of healthcare information in the country. We do work with about half of the large employers in the country, about half the hospitals, about half the health plans, most of the pharmaceutical companies, 31 state Medicaid plans. And when you put all of the data in from all of those sources, we have arguably the largest repository of information, mostly claims-based information, but also increasingly other sources, laboratory, pharmacy, health risk appraisals, electronic medical record feeds we're starting to get. So it's actually getting very exciting in terms of what we're able to do with data. And one of the things we looked at recently in this white paper, and another one that I wrote subsequently, is what percentage of the health care that we spend in this country is actually not going to make people better or to prevent them from getting sick. And so what percentage do you think that is? Well, is it 10% of the money spent in healthcare that's not spent on making people better or preventing people from getting sick? How many people think it's 10%? How many people think it's 20%? How many people think it's a third? Okay, that would be the correct answer, a third. So 1 out of every $3 in healthcare today is not spent making people better or preventing people from getting sick. Now, this particular white paper was actually utilized in the Obama Health Summit. And one of the senators actually raised their hand and said, well, according to, at the time we were Thomson Reuters Healthcare, according to Thomson Reuters, 1 out of every $3 that's spent is spent wastefully. So that comes out since we have about a $2.2 trillion budget in healthcare in this country. So there's about $700 million that we can spend better. And if you look at all the different buckets of waste, you have, between errors and omissions and a system that's really not functioning well, even from a billing standpoint, as many of you know or will know. And then there's stuff that we're doing that really doesn't have any science behind it. And then there's just actually, unfortunately, a criminal element in terms of fraud and abuse. And when you add it all up, it's quite remarkable. And this is an opportunity that we have to make the system more efficient and better. And this is the challenge for the next generation. This is, what we're unfortunately saddling you with in part. Now, one of the other issues then, so we're wasting a lot of money, but we're spending more and more and more on healthcare relative to the entire budget. So you can see here, I happen to ask my data geeks to give me a trend line of the last 50 years of appreciation in the amount of spending that takes place in healthcare relative to the consumer price index. So almost in every year since the last 50 years, whenever the inflation rate went up X, the amount of money that we spent on healthcare went up 2 or 3X. This is completely unsustainable. You can't have a country's income growing at, let's say, 4% and healthcare spending growing at 10%. You can't have that happen for 50 straight years and expect this to be sustainable. So what's happening is with each passing year, more and more of the total budget that we spend on health care. So then we don't spend it on education, and then we don't spend it on roads, and we don't spend it on balancing the budget. And so as opposed to what you may be hearing or reading about in the newspaper, and I'm actually going to Capitol Hill tomorrow in an advisory role, in Capitol Hill, the new aim isn't to lower how much is spent on health care. It's just to try to get health care to spend at the same rate as the growth of the country. So if the economy grows at 4%, then health care spending should grow at 4%. That's the new goal. It's just, we need to get health care spending under control, and it starts with just getting health care to spend at the same rate as the country grows. Now, the second issue is this issue of variation in care. Now, if you were a woman who's from the Southeast, anybody from a state in the Southeast, a woman, if you were a woman and you live in the Southeast part of this country, you're 3 to 5 times more likely to have your uterus removed in your life just because you live there. We haven't yet figured out why women in the Southeast have bad uteruses compared to everybody else in the country. So we call this unexplained variation. And if you're a male from the Pacific Northwest, anybody from Washington State, Oregon, if you're a male from the Pacific Northwest, you're 3 times more likely to have surgery on your back in your lifetime. And this is, I know people, there's maybe a few more lumberjacks out there, but we haven't been able to figure out why men in the Pacific Northwest get a lot more back surgery. And this happens repeatedly over and over again as we look across the country. Remarkable variations in cost and in utilization. Now, a lot of that initial study was done by Jack Wenberg at Dartmouth with the Dartmouth Atlas. How many people are familiar with Jack Wenberg and the Dartmouth Atlas? This is definitely worth getting familiar with as a medical student and as a resident. They used Medicare data. Now, no one had done up to last year when we did it, no one had actually looked at the commercial data. We assumed that since there was wide variation in the Medicare data, there would be wide variation in whatever payer we looked at. And sadly, I'm going to report to you that yes, we found wide variations in utilization and cost in the commercial data too. And there was a couple of other interesting findings. One is sad. As a medical manager, I have been in my career telling people that if you spend more money taking care of people on an outpatient basis, they won't have to go in the hospital as much, right? That's not what the data shows. It shows that if you find a place in this country where people are spending a lot of money on the outpatient side, they're spending a lot of money on the inpatient side too. So it just seems like there's some places where there's high utilization or high cost, and that translates across the outpatient and inpatient side, unfortunately. Good news is that where there are places where they're spending more money on medication and on drugs, it seems like they're spending less money on medical care, meaning that if people purchase their medicines and take their medicines, maybe we can keep them out of the hospital. So at least it looks like we have some substantiation on a national basis using commercial data to support the notion that medication adherence compliance is really a good thing. And when you look at these patterns, and you'll soon be able to download this white paper that I wrote off of the Truven Health Analytics site, you can see that there's marked variation in the patterns of where the high-cost areas are for children versus adults. It doesn't even match up when you look at children and adults. So there's a place in the country that can actually be very expensive for adults and be cheap for children and vice versa. So Atul Gawande wrote an article after the Dartmouth study that really generated a lot of interest. And one of the things that he said was McAllen, Texas has another distinction. This was based on the Medicare data from Wenberg. And he said, it's the most expensive place in the country to get care. Now, that was based on the Medicare data. Remarkably, our data actually shows that McAllen, Texas is the lowest place in the country to get health care in the commercial data. So I was interviewed in the press, and they said, well, what, Dr. Fabius, what's your comment? And I said, well, sadly, there's variation even in the variation. So Atul Gawande was wrong when he assumed that the Medicare data that identified a place being very expensive was also going to be expensive if we were looking at commercial insurance, not Medicare. And places where it's cheap to get care for Medicare may be very expensive for commercial insurance and vice versa. So I'm just trying to give you some sense here of how crazy the present system is in its variation. You know, I was the global medical leader at General Electric for 3 years, bathed in Six Sigma. This is the opposite of Six Sigma, where everything is, you know, perfected. There's very little error. Right now, you're working in a system that's really operating almost in Brownian motion, at least in terms of the utilization of services and costs and probably quality. Tremendous variation across the country. And that's where I want to talk for just a minute around the healthcare systems. Generally speaking, we don't fare well compared to other healthcare systems, even though we spend at least twice as much money as everybody else. And what's most disturbing is it looks like we're getting worse. There was some new data. I just taught a course on population health at Harvard School of Public Health last week, and some data came in from some of the other faculty at Harvard showing even more dramatically how we're falling off. So we're doing a bad job and we're getting worse. Other countries are actually really doing a better job. And one of the reasons they are, for example, New Zealand decided that they wanted to implement an electronic medical record, and because they have a socialized healthcare system, they were able to put all their doctors and all their hospitals on the same electronic medical record system. We have 73 certified electronic medical record systems. And, you know, as this, you know, wonderful institution here at Cooper has been able to get on board with Epic, that's just one of the 73 systems. So now, even after we get everybody on an electronic medical record system, then we have to figure out some kind of common highway to connect all the 73 together. Does everybody follow me? Yeah. And this is all under the guise of supporting a free market system. So we support a free market system that allows for all different kinds of insurance companies to contract independently with all of the providers, so that even here at Cooper, a service that you provide can be paid 14 different ways by 14 different insurance companies. And now we're supporting electronic medical record systems that have to now somehow interact in ways that will allow for some common translation and communication after we actually get everybody up and running. So this is what we're up against. And for those of you that want a quick answer to a likely question in a test, the answer is 55%. Okay, because when the studies that have been done that have looked at, well, how often is it likely that somebody in our healthcare system is going to get what they're supposed to get? Preventative services, acute care treatment, chronic care treatment. 55% is the answer. A little more than half. That's a system that really needs improvement. And hopefully these electronic medical record systems will make that happen. Now, we have developed a new vocabulary in healthcare reform, and I actually, I think you may have just gotten the copies, or I did, I think there's copies of this white paper that I wrote on the vocabulary of health reform. And it's particularly hard for older people to understand the new language. It's easier for medical students and residents to pick this up because there's something called retrograde interference, meaning that the things that you've learned before interfere with your ability to learn new things. And I thought I'd show you this video as an indication of that. Hold on. That's too low. Let's try it again.
I bought something from you last week, and I'm very disappointed.
Oh, yeah? What's the problem?
Yeah, well, my BlackBerry is not working.
What's the matter? Run out of juice?
No, it's completely frozen.
Oh, yeah, I can see that. I'll tell you what. Let's try it on orange.
I'm so sorry, the video's not transmitting well.
That's got a few black spots, you see.
Oh, dear, yeah. Sorry about that.
Yeah. Was there anything I do to get my BlackBerry working?
Well, it could be an application issue. But where'd you store that BlackBerry?
Which on my...
I'm sorry. Let me see what I can do. I think, you know, we'll keep going, but you get the idea. It's a cute little video. You can actually get it on YouTube. But I think it's not working well. A great place to start as you look at healthcare reform is to look at some of this new vocabulary. And in this white paper that I wrote that you have copies of, there are 4 categories of vocabulary. There are goals, there are payment issues, there are innovation and technology reform concepts, and then lastly, organization and operational reform. And we won't go through all of these vocabulary words because I think there's actually maybe 50 in there, but I thought I would share with you a couple. One is this concept of patient safety, which is one that you're either already familiar with or will be soon. And look at that jumbo jet. The Institute of Medicine suggests that somewhere between 44 and 98,000 people die every year in hospitals, in hospital systems alone, due to preventable medical errors. So we're not talking about the known side effects of certain medications, for example, that can cause a problem. We're talking about things that are preventable, like, you know, not washing your hands and giving a patient an infection. And it is amazing how this country has tolerated this kind of ineptitude in the healthcare system because of how crazy the country goes whenever there's a jumbo jet crash. And a jumbo jet is crashing almost every day in terms of the number of people victimized by the healthcare system that's supposed to teach medical students and residents first do no harm. Now, every year, Truven Health Analytics gives an award out to hospitals that are in the top 100. And we did a study ourselves just looking at Medicare data, and we said if everybody performed, if every hospital in the country performed the same way as the 100 top hospitals, we would be able to prevent 186,000 deaths just in the Medicare data and save about $4.3 billion. A couple other terms that I thought I would share with you are the concepts of bundled payments. How many people understand bundled payments? Okay, good. And medical loss ratio. How many people know medical loss ratio? Okay, and how many people know this concept of pay or play, the employer mandate that we talked a little bit earlier about, okay? So let's talk about those. So it is possible, when we looked at our data across the country, this is what hospital systems are being paid for bypass surgery. So, you know, there's sort of this average number that you're getting paid probably, you know, somewhere around 40,000. There's a median number here around 35 to 40,000, and then there's some that are getting paid a lot of money for bypass surgery. And the ones that are getting paid a lot of money for bypass surgery are usually ones that are associated with complications. So right now, the healthcare system actually rewards hospital systems that have more complications with more money. It's the reason when I say to my friends in other cities and they say, how do I figure out which surgeon should I go to? I say, beware of the ones that are driving Maseratis. They may be making the most money because they may actually have the most complications. Now, the healthcare system's just starting to look at how they have to change this now. And the concept of bundled payments is one of the ways to reward those systems that are more efficient and maybe have shorter lengths of stay and less complication rates by paying a bundled payment. So now contracts are being set up with hospital systems that just say, look, we're going to pay you $45,000 all inclusive for this patient's bypass surgery. That's going to include the pre-op work, the post-op rehabilitation work. It's going to include every specialty visit associated with this. It's going to include the surgery. It's going to include the hospital days. And so those hospitals that become more efficient and those providers that work in coordination with each other are going to be the ones that actually make the most money. This is the concept of bundled payment. Now, we talked a little bit about this, and employers are going to have the opportunity now to either provide coverage of insurance for their employees or pay a penalty of between $2,000 or $3,000 per employee. And so they have to go through this analysis as an employer to decide what the right thing is to do. By the way, I mean, we did this analysis. There's a white paper that we wrote that actually shows that employers that provide healthcare insurance now will overwhelmingly likely continue to provide coverage because it just makes good economic sense. As people have the option of buying their own health insurance on individual exchanges, which are coming forward in 2014, employers may just pay the penalty and say, I'm going to just pay $2,000 or $3,000 in penalty, and my employees can go to the individual health exchange and buy their insurance there. That's possible for smaller employers. But at the same time, the Accountable Care Act provided tax incentives for employers to provide this coverage. So it's going to be a very interesting decision how it all plays out. Lastly, again related to payment, the Accountable Care Act says to insurance companies, for every dollar that you collect in premium to cover somebody, you have to spend 85 cents of those dollars on care. And your administrative costs and your profit has to come out of that last 15%. So that's created some new challenges for health plans and insurance companies. As you can see on this grid, many of them have not been spending 85% of their dollars on health care. They've been spending closer to 80%. You can see here 82%, 82%, 82% here. Only a few have actually been over on occasion. Now, lots of new vocabulary on IT side, and I suspect the medical students know these vocabulary words better than perhaps others, but e-prescribing, you know this concept of e-prescribing. So we're now getting to the point where we can eliminate the errors of scribbles that happen in handwritten prescriptions because the pharmacist can't really interpret somebody's handwriting. And that's a big, big plus. And then other things like, I forgot to turn off my phone. Other things like clinical decision support. I mean, you folks are going to practice in a day where the computer may actually help you and say, well, it looks like this patient is missing some care or service that they're supposed to get. They're a diabetic and they haven't had an eye exam for a year. Alert. And this should be a tremendous assist to improving that 55%. So this concept of clinical decision support is coming forward too. Not to mention all of these things like patient monitoring. I don't know if you saw this, but for $100, you can take an iPhone and put it into a contraption which allows, by putting your thumbs on the back on both hands of your iPhone, to create an EKG. which then could be transmitted to your cardiologist. So if you have a problem with your heart rhythm, and and maybe you're actually feeling some palpitations while you're walking, you can actually capture the EKG while you have the palpitations and send it to your primary doctor and your cardiologist. I mean, that's what's coming forward. And I share some of this to the residents and the medical students in particular because I want you to start to imagine what's possible with a smartphone as we move into the future. There is a prediction that just establishing this IT layer in healthcare, even with the 73 different kinds of electronic medical records, there'll be tremendous savings. And the calculation here suggests maybe as much as $1 trillion over the next 15 years in savings in healthcare. And not to mention a lot of other really good things. 400 million work days saved, 200 million school days saved, 600,000 lives saved from going on to electronic medical record systems. I mean, this is something that, to give President Bush credit, the second Bush, W, he's the one that actually started this process. He's the one that hired the first health IT czar. And he was the first one to really recognize that one of the ways to make healthcare more effective and efficient is to really force the issue of an electronic platform. Okay, and this is an area of my greatest interest, and you can see in my book, the book title is called Population Health, but the subtitle is Creating Cultures of Wellness. So this concept of a culture of health is becoming a big war cry, particularly for employers who are trying to figure out ways to make their own workforce healthier, not because they want to be a nice person, but because a healthy workforce is a competitive advantage. And there's some evidence now that you can engage in a roadmap process to build a culture of health. And one of the places where it's starting to gain some momentum is in healthcare systems themselves. Because one day I woke up and others and we said, hey, wait a second, healthcare systems are employers too. And in some places around the country, they're the biggest employer. You might be the biggest employer in Camden, Cooper system. If not, you're one of the biggest. And so, you know, I thought it'd be very interesting to look at how healthcare workers access the healthcare system. And you would think, as medical students or residents, oh my gosh, they're going to show us the way, right? Healthcare workers. No, they're not. And in fact, they overutilize all the healthcare services in the healthcare system, except for the one that we might want them to overutilize, which would be called what? Primary care, outpatient care. So hospital workers don't really use primary care doctors. They just go to emergency rooms. They just go to specialists. They bump their elbow while they're working and they go right to the radiology department for an x-ray. They don't engage in collaborative healthcare services. And as a consequence, their healthcare costs are at least 10% more than the average worker, and every hospital system is paying for that. It's another form of waste in the system. We also looked at the illness burden of hospital workers. No matter what disease category we looked at, there's more of it in hospital workers. They have more chronic illness. As a medical student or as a resident, you should reconsider this field if you're interested in your own health. Because the hospital industry, as an industry, is doing the opposite of a culture of health. I don't know what that's called. A culture of toxicity. I mean, they teach you from the start about a, on-call schedule. I know your world is a little bit better than mine was, where I was on every third night and I had some every other night responsibilities, and, I had teachers that would say to me, it's so unfortunate that you can't be on every night because you're going to miss half the pathology by sleeping. So we have a way to go in terms of treating our own workforce in a way that creates a culture of health so that our own healthcare workers can be good examples for the community. So that leads us to this concept of these 5 enduring trends. One is this idea of building collaborative relationships. In the research that we did, we looked at somebody who has congestive heart failure. The average person with congestive heart failure has 19 points of access to care in a year. There's 19 different things that they have to manage in a year if they have congestive heart failure. And of course, they're often in the twilight of their life where they actually have a hard time keeping things together anyway. Now, how do you actually deliver on a healthcare system for these people in a coordinated way? How many people are familiar with Clay Christensen? He's really the #1 voice, perhaps, in terms of innovation in this country. He wrote the original book, The Innovator's Dilemma. But he wrote a book on healthcare called The Innovator's Prescription, where he said healthcare systems like Cooper should establish a solution shop where the congestive heart failure patient can come in and get all 19 services that they need on the same floor or in the same building. And so at the end of the day, they can walk out the exit almost like a conveyor belt and get everything that they need. Now, how would they do that? Well, from a population standpoint, we looked at this for them. And we said for every 1,000 patients with congestive heart failure, you're going to need 640 office visits. You're going to need 240 hospitalizations. You're going to need so many of them to be cared for in the home. You're going to need this many home visits and hospice visits. This is the way I want you to start to look at the world. Not that you shouldn't also treat each patient, but if you can group patients together and treat them as subpopulations and manage them in concert, you can get them more services than you could ever get a single patient one at a time. Solution shops, subpopulations, population health. Here's another study that shows that just by doing e-prescribing and using clinical decision support, we should be able to reduce drug misadventures by 61%. 2% of all hospitalizations in America are due to drug misadventures. It costs us about $2 to $3 billion a year just from making mistakes with medications. And that's just the inpatient side. So this offers tremendous opportunity for better collaboration between the prescribing clinician and the dispensing clinician. How many people are familiar with accountable care organizations? This is supposed to be the ultimate solution in terms of collaboration, where hospital systems work with the providers in the community and take care of a population which they get paid for on either a capitation or a shared savings relationship. And in order to have an accountable care organization, you need these kinds of elements. Inside the industry, we often joke that an accountable care organization is a lot like a unicorn because it's a beautiful concept, but nobody's ever seen one. But we're working on them now, and there's 73 pilots that are funded by the government to see what may work. And the ones that are most likely to work are the ones that have experience as a health plan as well. So a Kaiser system or a Geisinger system that understands the idea of health plans and payment and risk, and also understand patient care. The interesting thing is we did a study that actually showed that 45% of doctors as of July of 2010 didn't know what an ACO was. And of the ones that did, 20% said, I'm not going to work, I'm not going to participate in it. So we have a long way to go between the conceptual idea and actually providing the basic knowledge, again, around this concept of new vocabulary for doctors, and then getting them to understand the value of participating. Another trend is this trend called striving for perfection. And you're seeing now this idea that providers are the best providers are being called E squared or E2 providers. These are providers that are the most efficient and effective, right? E2, E squared. And for those of you that get more involved and interested in this topic, you're going to see over time, you'll see providers and hospitals or individual doctors that are really good at being efficient, but may not be good at quality. Or they may be good at quality, but not be good at efficiency. And then you'll have some providers and hospital systems like the ones that are in 100 top hospitals that are good at both. And you want to try to move as many of the providers in the system into becoming efficient and effective. So you can either push them by going to visit with them and saying, these are the things you need to do to get to here. Or you can pull the whole system, which is the approach I like to take, which is find out who's the best in your system, who's the most efficient, most effective, and actually work with them to make them even better so that they can be the model, and then have all the other providers in the community walk through that practice. Here's what the best is doing. Good luck. Try to mimic this. Now, I'm actually suggesting, as a consequence of the importance of this, that there be a new position inside of hospital systems called the Chief Efficiency Initiation Effectiveness Implementation Officer. And the reason why I say that, and it's the reason why it's a job I would like to have, is because you would then be the CEIEIO. Now, I told you before, every one of these little dots is a hospital in the American healthcare system, and these purple dots are 100 top hospitals. So the best hospitals in the country are the most efficient and most effective. And when you look at individual parameters, they have lower mortality rates, they have better quality measures, they have less adverse events in terms of patient safety. On the efficiency side, they have higher satisfaction surveys, they have less expenses, and they're more profitable. How wonderful is this? Because you actually can be effective and efficient. It is possible. And all the other hospitals should be trying to mimic the performance of the top 100. Now, the third trend, is, as we've already alluded to, is this trend of paying on merit and with integrity. So we have to get rid of fraud and abuse, and it's everybody's responsibility. And unfortunately, in the healthcare system, particularly with Medicare and Medicaid, there are organizations out there billing for services that they don't provide, or worse yet, doing things to people that shouldn't be done in order to be able to generate a bill. Fraud and abuse. But on the better side is this idea of paying doctors with bundled payments and with global payments and based on their performance, the so-called income for outcomes. Right? Pay doctors, hospital systems more money if they're delivering better care. Paying on integrity and on merit. There are a couple of key programs out there that are doing this. One that you can look up called Bridges to Excellence, and another one in California, Pay for Performance program. I do know that the medical students may have to leave close to 1 o'clock here. So you got to at least 3 of the 5 trends. So if you have to go, I understand. Thanks for being here. So employers, and thankfully for all of you, are now trying to figure out ways to provide incentives to your patients who are their employees to do the right thing. And now, increasingly, they are paying their employees a little bit more money if they do things like a health risk appraisal, or if they get their blood tested for cholesterol and other things, if they get a flu vaccine, if they actually establish a relationship with a primary care doctor, they can get more money. Or they may even, on the better side of things of this effort to provide incentives, they may give them better benefits. So some companies are saying, here's your basic benefit package. If you want better benefits, then I want you to go see a primary care doctor once a year. If you want better benefits, then I want you to get a health risk appraisal. I want you to get a flu vaccine. I want you to, if you're diabetic, get an eye exam. I mean, there are increasingly personalized ways for employers to say to employees, based on your medical record, these are the things you need to accomplish over the next year in order for you to get better benefits, or more money paid into your health spending account. I mean, ultimately, we would hope that what would actually provide an incentive for people would be better health. That would be intrinsic reward, right? We have to get there. That's what a culture of health is really all about. These are a couple of things that employers have done. Now, the fourth trend is this idea of promoting transparency and accountability. So the transparency part is very hard for providers, but it's coming. I mean, patients are going to eventually know how every hospital's doing with every procedure. It's going to happen. But before that happens, what's going to happen first is probably price transparency. And there are some insurance companies like Cigna where you can already go on their site if you have Cigna insurance and you can find out how much a procedure is going to cost if you do it at one hospital versus another. Price transparency. But quality will be happening too. Because of this, though, we're also going to say to the consumer, you have to be more accountable. Look, we're going to give you more data, but then you have to act on it and you have to be a better patient. I mean, that's this trend of transparency and accountability. So there's a study, a white paper, which you can download off our site, which suggests that if we just provided price transparency in this country, we could save $36 billion a year. And here's an example, just, you know, as one, this was in the Detroit Free Press, one of their leading papers. Look at the variation in cost for a C-section in Detroit. I mean, it's the difference between $7,000 and $11,000. I'm sorry, $13,000. It's about 2 to 1 for the same procedure. And there's no evidence that one place is better than another. It's not like you're buying better quality. It's just the way it is. We did this study with a large employer where we started to provide pricing information. And based on our initial data, we think that in a 3-year period, an employer with 20,000 employees could save about $7 million just by providing price transparency, because their employees would actually make some decisions based on price. On the accountability side, what's getting very interesting is we are able to increasingly provide sophisticated, personalized messaging to people, telling them what it is that they need to do in the coming year to take better care of themselves. And it's been most effective when it's actually been delivered with the signature of their trusted doctor. And you can see how that could all become automated. And in this one study, just in a single year at an employer location, we were able to markedly see improvements in screening procedures just by providing this personalized messaging. You know, so that messaging around breast cancer screening just went to women over the age of 40 or 50. You know, that colorectal screening only went to adults over 50. Again, this is a copy of my book, and this is the area, this is the last trend, this is the trend that excites me the most, that I really want to leave you with, this concept of health and wealth, because as we see changes in the way the healthcare system gets reimbursed, there's a remarkable opportunity for healthcare delivery systems and individual providers to get paid new ways by keeping populations healthy. Oh my God. The opposite of the way you get paid now. What we know right now, though, is that because of the increasing cost of healthcare, in the last 10 years, the average wage earner hasn't gotten any raise in their salary. All of their raise has gone to increasing healthcare costs. So in the last decade, the healthcare cost growth has completely wiped out income gains for the average American. Another reason why we have to try to contain healthcare costs so the average person can start to get raises again, so that there can be prosperity in the country. This is an interesting study which actually shows that you can't get sick and be able to figure out a way to pay for it in your retirement. Anybody's retirement plan, your parents' retirement plan, has to start with being healthy in retirement because you can't afford illness. I mean, this is a study that shows the costs per age band of retirees based on whether or not they're in good health or poor health. Good, excellent health, poor health. I mean, the difference is extraordinary. This is out-of-pocket costs, even with Medicare intact, which, you know, we can wonder whether that will be the case going forward. So part of a retirement plan has to be good health. And by the way, the fidelity organizations in this country are starting to move, they're starting to infringe into this business of health care when they sit down with retirees. And they may want to hire integrated delivery systems in certain communities to help their people who they're managing their wealth for stay healthy. This is a fascinating study done by Towers Watson. There's a small subset of employers who've worked very hard to try to make sure their employees stay healthy. And that subset, that group that have the most effective health and productivity programs, have 39% higher revenue per employee. And they have an 18% better track record in the stock market. Health and wealth. You have it in your power. In a sense, the healthcare delivery system can provide prosperity to a community. That's not what you're doing right now in Camden, but it is the potential. I mean, if you could take this Camden population, and if you decided, like Thomas Jefferson, to start a new school of population health here in Camden, and you work to elevate the health status of the population just here in Camden, it would be a contributing factor toward improving the prosperity of this really, you know, challenged city. Yes. Yes, yes, yes. I mean, it's the reason why I think the new school, the new medical school here, ought to actually build out, like Jefferson has, a population health school. I look forward to it. So here's another interesting study which shows that on the state level it's true. So those states that are the healthiest are the wealthiest at a state level. And now I'm going to close with, I think, a remarkable story over the last 200 years that's with all the challenges that I've presented to you as residents, as faculty, as medical students. This is actually remarkably upbeat. Hans Rosling, anybody have seen this video? Hans Rosling, who is one of my heroes in healthcare data, looked at the last 200 years and the connection between health and wealth.
First, an axis for health, life expectancy, from 25 years to 75 years. And down here, an axis for wealth, income per person, $400,000, $4,000, and $40,000. So down here is poor and sick, and up here is rich and healthy. Now, I'm going to show you the world 200 years ago, in 1810. Here come all the countries. Europe brown, Asia red, Middle East green, Africa south of Sahara blue, and the Americas yellow. And the size of the country bubbles show the size of the population. And in 1810, it was pretty crowded down there, wasn't it? All countries were sick and poor. Life expectancy were below 40 in all countries. And only UK and the Netherlands were slightly better off, but not much. And now, why start the world? The Industrial Revolution makes countries in Europe and elsewhere move away from the rest. But the colonized countries in Asia and Africa, they are stuck down there. And eventually, the Western countries get healthier and healthier. And now we slow down to show the impact of the First World War and the Spanish flu epidemic. What a catastrophe. And now I speed up through the 1920s and the 1930s. And in spite of the Great Depression, Western countries forge on towards greater wealth and health. Japan and some others try to follow, but most countries stay down here. Now, after the tragedies of the Second World War, we stop a bit to look at the world in 1948. 1948 was a great year. The war was over, Sweden topped the medal table at the Winter Olympics, and I was born. But the difference between the countries of the world was wider than ever. United States was in the front, Japan was catching up. Brazil was way behind, Iran was getting a little richer from oil, but still had short lives. And the Asian giants, China, India, Pakistan, Bangladesh, and Indonesia, they were still poor and sick down here. But look what is about to happen. Here we go again. In my lifetime, former colonies gained independence, and then finally they started to get healthier and healthier and healthier. And in the 1970s, then countries in Asia and Latin America started to catch up with the Western countries. They became the emerging economies. Some in Africa follows. Some Africans were stuck in civil war and others hit by HIV. And now we can see the world today in the most up-to-date statistics.
And yet, despite the enormous disparities today, we have seen 200 years of remarkable progress. That huge historical gap between the West and the rest is now closing. We have become an entirely new converging world. And I see a clear trend into the future. With aid, trade, green technology and peace, it's fully possible that everyone can make it to the healthy, wealthy corner.
So what does this mean to you? First, there's a transformation in healthcare underway. Second, there's a new vocabulary that you need to master. Third, there are some enduring trends that you need to understand because they will help you as you actually take the lead going forward as the next generation of healthcare leaders. And I'm so sorry that it's going to be up to you, all of you, to lead that charge because the nation is depending on your leadership going forward. Thank you so much. Now, is there time for a couple questions? I think we have 5 minutes, right? You guys have to go. I'll stick around for some. Yes, questions. Here, you can.
Heterogeneous population we have, and a homogeneous population that some countries have, and try to take out the socio-educational and social and other ills, lack of education and so forth that some populations characterized by it. What happens then to the healthcare statistics and our costs and
right.
our progress? So, how good a product could we deliver to the better educated upper crust of our country, so to speak? Would it be as good as Sweden's? Would it be as good as Switzerland? I mean, those are countries that have not had the social problems. Now, Germany didn't have them, but now Germany has them. With the,
even Sweden now, 16% of their population is not indigenous. You know, they're getting pretty massive immigration coming into their country now, and that 16% is growing. But your point's a very good one. So let me just first answer it this way, which is, if you look at the health care of white men who are wealthy and who speak English, these are the 4 parameters. That care in this country is pretty terrific. Now, if you're a poor woman who doesn't speak English and doesn't have, and doesn't have, any support structure, they get third world care. So, speaking English is a predictor of better care in this country, obviously. And then, obviously, if you are well-to-do, it's a predictor. If you're male and if you're white. But that poor Hispanic woman who doesn't speak English is really in trouble. You know, so your point's very well taken. We don't have a healthcare system that's really been able to deliver on with a heterogeneous population in a homogeneous way.
I mean, if you took the 100 poorest cities in the country, the Camdens, and now I understand Reading is second, which surprised me, and that level economically is city, and compared, it took them out, our maternal death rate, fetal death rate, whatever, would be very, very much better, would it not?
Yeah, but here, I mean, other countries, interestingly though, are getting less homogeneous, but are still performing better. So like the Swedish healthcare system, even though it's accepting people from all over the globe, is still making progress. And the sad part for us is as we continue to accept people from other countries, which is just sort of part of the American ethic, we're performing more poorly. We're losing more and more ground relative to other countries.
But it underscores the issue. It's not an issue of health care. It's an issue of solving the social problems inherent in delivery of the health care.
Well, but you know, that's what population health is about in part, right? I mean, it's the reason why I've been telling at least employers that you can't manipulate the benefit structure in order to reduce your health care costs long term. I mean, you can shift costs to your employees a couple of times and save some money from one year to the next, but over the last 20 years, the premium escalation for employers has been going up at about 7% per year, which is, you know, breaking the back of American enterprise. What employers have to come to grips with is there's only one way to reduce the health care burden of their employee population. That's going to be making their employees healthier, which is a cultural transition. It's not just, getting a physician involved, although, you know, one of the elements that, you know, I've been very involved in is getting doctors at the workplace, putting primary care centers right at the workplace, at least for, you know, populations that are large enough.
And certainly if you got rid of the fact that so many of us are overweight, you would solve a huge health problem right there.
Well, I mean, there's
stop cigarettes would be the other.
I mean, you know, and the beauty of that, first of all, there's some studies that show that 80% of the of chronic illness costs, which is 2/3 of the escalating driver for costs, is related to obesity. You know, so you got like 50% of the driver of all of the escalating cost of healthcare related to obesity. So, I mean, you hit it on the head in terms of that. And in a study that we did at Truven, we looked at risk factors, and by far the greatest risk factor for cost of an employee's health care was their weight. And BMIs over 30, you know, were much more likely to have a much greater cost, you know, in terms of their annual health care expenditure. So that's true. And second, actually, was elevated blood sugars. Not yet diabetic, but the metabolic syndrome risk factor. And then third was smoking. So, you know, the good news about that, dear employer, dear community, is it's not like we have to solve 85 different things. We only really have to solve probably 4 or 5. I mean, you might want to put alcohol consumption in there, you know, and actually there's studies, as you know, show that moderate alcohol consumption is protective. It's just that when you go, you know, above, and we don't really know exactly how much, but it's probably above maybe 3 or 4 drinks a day. 2 are certainly protective. And so in our studies, when people drink 2 drinks of alcohol a day, like 2 glasses of wine a day, their health care costs...
Glad to know I'm doing something right.
All right. That's a start. That's a start. That's really good. So, there was one of my colleagues, Nico Pronk, who is, some people think, the #1 expert in the country in wellness. He and I taught the course at Harvard last week. He did a study using health plan data where he studied people for 4 consecutive years in the same health plan, where they consistently reported that they drank in moderation, their weight was 25, BMI of 25 or better, so they had a normal weight. They didn't smoke, and they exercised at least 4 days a week. That population had, as they trended them, had remarkably lower rates of some things that might surprise you, like cancer. I mean, they had lower rates of heart disease, but we could understand that. But a little less well appreciated is less cancer. And when we looked at almost anything, they had less of everything, dramatically less of everything. Now, we used to say to employers, it's going to take a long time for you to get the payback if you get the employees to abide by these simple, better lifestyles. But now the studies are actually showing it doesn't take that long. Like if you build a culture of health inside an organization, within 3 to 5 years, their healthcare costs can go down. And there are now companies, there's a 3-part series that Navistar is just published in the Journal of Occupational Environmental Medicine, peer-reviewed journal, that shows the remarkable success at Navistar. And we helped to publish a similar article at Johnson & Johnson. Dow Chemicals, another one that's published lots of things. So it is possible in a short period of time, attending to certain lifestyles issues to remarkably improve the bottom line and the health status of the workforce. And by the way, I mean, I teach a course for the American College of Occupational Environmental Medicine on the connection. It's a whole day course on the connection between health and productivity of a workforce. And the studies actually show, dear employer, for every dollar you spend on healthcare costs, you're losing $3 of productivity. So again, I mean, for Camden, if you elevate the health status of this community, you elevate their productivity, their potential productivity anyway, because they're able to go to work instead of. I mean, one thing that we know, because we take physics as a prerequisite to getting into medical school, is that if somebody's in the hospital, they're not at work. So as soon as you put somebody in the hospital, you're taking them out of the workforce. You ought to be so resistant to doing that. And it should be the last thing possible, because when you take them out of the workforce, you reduce the prosperity of the whole community. Now, you mentioned, for example, Reading. And maybe I'm speaking a little bit out of school, but we're among friends. So the data is actually pretty interesting, because if you first look, when I was a corporate medical director at US Healthcare and Aetna, and you started to look at Reading, you'd say, oh my God, Reading does something very special. Their unit costs are remarkably low. How are they actually surviving and doing as well as they're doing? And then you start to look and you see, oh my God, they're overutilizing services to an extraordinary degree. They have 3 neurosurgeons that are busy all the time serving a community that shouldn't even support one. So that means that 2 out of every 3 surgeries that the neurosurgeons are doing at that institution are unnecessary.
Unnecessary spine surgery.
Right. So I can tell you then, because I was the corporate medical director for national accounts for Aetna, that big corporations that had big facilities around Reading left because their healthcare costs were too expensive and because their people were not at work.
This brings another question, which is, it seems to me that our capitalistic system in medicine has failed us. Docs are incentive, of course, the payment system favored it, but you're incentive-based to do more procedures, you're incentive-based to pass your patients around to all your friends, and you scratch my back, I'll scratch yours. There's unnecessary referrals. It's true at so many hospitals, everywhere. And then there's this place in Texas, the name of which I forget.
Yeah, McAllen.
Yeah.
Look, I would have to say most of our peers in healthcare went into healthcare because they wanted to help people.
Well, sure.
And most of them still really want to do that. But you are right. I mean, the compensation system is perhaps the thing that has to change the most. I mean, one of these 5 trends that I spoke to, which is this issue of paying on merit, is a way to eliminate what is otherwise a moral hazard, right? I mean, dear doctor, if you really do a great job with this patient and you get them out of the hospital quickly and they don't have any complications, we'll pay you less. Well, that's not a good, right? It's not a good system. So we have to fix that. But I mean, the average doc is still out there trying to toil and make a difference with their patients all the time. I mean, they may not be aware of the fact that they're not doing as well as others, and that's one of the things that we really need to work on. I mean, when I was a network medical director for U.S. Healthcare, and my responsibility was to go out and visit doctors' offices, and I would always show them how they're doing compared to their peers, because we had data to show this. Before I started, I used to joke that 90% of the doctors that I visited told me they were in the top 10% in their field. And it was always a joy when I was able to share that data with the 10% that actually were on top to justify it. But most of them weren't on the top. But they thought they were because, you know, one of the problems with the system is we don't even give the doctors any feedback on how they're doing compared to peers. Other thoughts? Yes?
Where's the money for the pay for Medicaid for coupling? Is that from governments, private,
Well, interestingly, in 1987, at U.S. Healthcare, which is, you know, subsequently was purchased by Aetna, we instituted a compensation system which we called the Quality Care Compensation System, QCCS. And we actually calculated that, you know, if certain things were being done, certain other things didn't have to be done. If people actually got preventative health care services, then they were less likely to be in the hospital. And so, you know, you were able to take the monies, all the monies that are due to, in terms of compensation back to providers and sort of redistribute it in a way to reward better performance. And that's generally how the insurance companies have done it. But it isn't a zero-sum game, because the more preventative services that are being done on the front end, the more savings take place on the back end that don't have to get spent at all, that can be redistributed into rewards. You follow me?
at the end, it has to come down those costs, right? So
They don't have to come down. Remember what I said to you. They have to come down to the point where they're only escalating at the general rate of inflation. We are not interested. The war cry, despite what you might want to read or what doctors might want to tell you, it's not, dear resident, you're going to get paid less than you got before as an industry. No. We're going to pay, you know, how much what's the inflation rate right now? Well, I mean, make it up. I don't know. You know, it's low right now. You know, we're only growing. The inflation rate's only maybe 2-3%. So healthcare can only get paid 2-3% more next year than this year. That's just the way it's going to have to be. The healthcare system can't continue to get more money than the country's growing. It has to grow at the same rate as the country. And by the way, if the healthcare system, as I've shared with you in the last trend, if the healthcare system can actually make the American population healthier and more productive, then the GDP is going to grow at greater than 3%. And there will be other times when the country's growth is going to be 7%. And you'll be able to, and healthcare will be able to grow at 7%, which is a very healthy raise.
How long do you think the American government re-examine policy of allowing pharmaceuticals to replace their market? Depends who wins the election.
Well, but you know what? We're just starting to talk about this in the pharmaceutical world. But to me, the pharmaceutical world should be reimbursed the same way as we would hope the future of healthcare gets reimbursed. So, in other words, a pharmaceutical company should not get paid by the pill that they dispense, because all of us know that when we go into our own medicine cabinet or we go into the medicine cabinet of our friends and loved ones, there's literally thousands of dollars of medication never utilized. So the pharmaceutical company should only get paid based on the results of actually utilizing the medications, and they need to be incentivized to improve medication adherence. You know, when I was at a big conference, I was one of the keynote speakers on this, and you know, they didn't invite me back, but I started my presentation by saying, you know, you can't blame the consumer for not taking their medicine. You have to figure out ways to get them to take the medicine. And I said to them, I said, look, I'd suggest that you start by not making medicines that people have to take 4 times a day. They can't do it. It's impossible. And by the way, if they're on 5, you know, Dan's grandfather, my father-in-law, who we lost just a couple years ago in his 90s, used to kid. He had so many medications that he had to take at so many different times, and he was a radiologist. And he said, the only way I can be compliant with my medications is if I sit next to the sink with a Dixie cup and a timer. That would be my whole day. Because nobody actually stood back and said, wait a second, this is crazy, this regimen. And so we have this concept of medication therapeutic management coming forward, where PharmDs look at all of the medications that somebody's taking and rationalize it in a way that they only have to take pills maybe twice a day. Or I say to the pharmaceutical company, why don't you make something that you only have to take once a month? I think I can get people to do that. Or why don't you give me a cure, for God's sakes? I'll pay a lot of money for that. But by the way, I mean, you know, the further inference of your question is, right now, if a pharmaceutical company had in their hands a medication that someone would have to take 3 or 4 times a day for the rest of their life to manage their chronic illness versus a cure, the economics are, you better hide this cure. Other thoughts? All right, thank you very much. It's been great.